So hello everyone and welcome to this important session on imaging in demyelinating disorders of the central nervous system. So here I'll be discussing some important demyelinating disorders, their specific imaging features and their differentials. So this will be helpful for radiology as well as medicine residents. So white matter diseases can broadly be classified into two main categories: demyelinating disorders, that is quantitative loss of normal myelin that has been formed, or dysmyelinating disorders, that is defective formation of the myelin itself, which is actually a qualitative loss. So here in this session we'll be mainly dealing with the demyelinating disorders of the CNS, which can again be classified based on the etiology into primary or idiopathic, which the etiology is unknown, and secondary, where there is an underlying etiology, known underlying etiology. Primary or idiopathic demyelinating disorders include central as well as peripheral demyelinating disorders. Central demyelinating disorders most commonly is multiple sclerosis, then acute disseminated encephalomyelitis, transverse myelitis, while peripheral demyelinating disorders include Guillain-Barré syndrome and CIDP, that is chronic inflammatory demyelinating polyneuropathy. Coming to the secondary demyelinating disorders, where the underlying etiology is known, which include infective as well as para-infectious conditions. Infective etiology include progressive multifocal leukoencephalopathy, that is a reactivation of the JC virus because of immunosuppression. HIV encephalitis. Toxic causes include osmotic demyelination. Nutritional causes include Markia fava bignami, which is very commonly seen in alcoholics. And vascular causes include deep white matter ischemia, which can lead to secondary demyelination. So coming to the imaging features of demyelinating disorder, typical demyelinating disorder, on CT it is difficult to detect. And most commonly, the abnormality that can be seen is discrete hypodense areas within the white matter of the CNS. But they are very non-specific, and MRI is the investigation of choice for evaluating any demyelinating disorder, in which a typical lesion shows a low signal on T1 weighted images and hyper intensity on T2 weighted images. Then and they predominantly affect the white matter in the juxtacortical area. And the important thing that we have to remember is that a typical demyelinating disorder does not calcify and does not show any significant mass effect. It may or may not enhance depending on whether the lesion is active, and it may or may not show restriction on DWI, again depending on whether the lesion is active or not. So now coming to the imaging protocol for a suspected or a proven demyelinating disorder. So these are all the sequences that are to be done, and why they are to be done, and what is the significance of each and every sequence that we'll be seeing later on as we go in the video. But just to give an overview, so axial T1 and T2 weighted images are very important. On T1 weighted images, the black hole as well as volume loss are seen in chronic cases, and it also is used to assess the neurodegeneration. On T2 weighted images, plaque morphology, location, burden can be assessed. The most important sequence, if someone asks, that is if only one sequence that you can do in case of any demyelinating disorder, is 3D flare. It is a very important sequence, and it's a volumetric sequence. So 3D means you can construct in all the three planes, axial, coronal and sagittal, where the morphology of the plaque, the location of the plaque, the size and the shape can be very well assessed. Each and every single lesion has to be assessed. The number of the lesion also should be given in the report as to whether it is 10 to 50, 50 to 100, the burden, the location, and this is very much possible in a 3D flare sequence. Then diffusion weighted imaging, as I already discussed, is to look for any active demyelination, and so is the 3D T1 post contrast image, where the enhancement pattern and the number of enhancing lesions can be looked for to actually assess for dissemination in time criteria. The diffusion weighted images cannot replace the T1 post contrast images, what we have to remember here. They are just supplementing sequence. Then susceptibility weighted imaging, where we can assess the central vein sign and paramagnetic rim sign, which I'll be discussing later in the video, which are very specific for multiple sclerosis. Then in any case of suspected or proven demyelination, it is very important to get optic nerve as well as spine screening done along with the brain MRI, because demyelinating disorders have a very high predilection for involving the optic nerves as well as the spine when they are involving the brain. And we'll be seeing the patterns of involvement in different demyelinating disorders as well when we go further in the video. So in MRI orbit, coronal, axial, T2 and post-contrast fat-sat T1 weighted images are very important, and sagittal stir spine is more than enough for screening purposes. Other sequences like magnetic resonance spectroscopy and diffusion tensor imaging can also be used in the imaging protocol if we are suspecting neoplasm as a differential for this particular condition. That is, if it's a tumefactive demyelination with mass effect, then we can get a MRS and DTI done to confirm whether it is actually a neoplastic etiology or demyelinating disorder. So in all suspected cases of MS, we do a 10-minute delayed contrast study with a 0.1 millimolar macrocyclic agent. Why we use a macrocyclic agent is also very important, because the linear agents deposit in the dentate nucleus and the deep gray nucleus in the brain, and they cause symptoms. And in MS, we need a frequent follow-up of the patient. We need to keep giving contrast, and it is better to use a macrocyclic agent than a linear agent. And a 10-minute delayed contrast study will also help in demonstrating all the lesions. That is, the lesion load can easily be assessed if we do a 10-minute delayed contrast study. So this was the entire protocol, which will be clear in later on in the video as we go into each and every single demyelinating disorder. So now coming to the first demyelinating disorder, I'll be discussing them in the form of cases. So here we have a 40-year-old female who presented with numbness and tingling of the left upper and lower limbs with blurred vision and intermittent episodes of fever since the past 5 months now. And this is the MRI picture. And as I already discussed in the imaging protocol, these are the flare images. And these are the most important sequence that is to be assessed in case of any demyelinating disorder. So these are the axial flare and sagittal flare images. So the findings, what do you think the findings are in this particular uh, case? So as we can see, there are discrete hyperintense signals that are seen in bilateral cerebral white matter on these axial images, which on sagittal images we can see are perpendicular to the corpus callosum, and they are radiating outwards like fingers. Now, these are the T1 post-contrast images and the diffusion weighted images. So where we saw the abnormal signal on the flare, we also see subtle post-contrast enhancement and some restriction on DWI, suggesting active lesions. So these were the lesions of multiple sclerosis. But according to McDonald's criteria of 2017, we cannot label any lesion as multiple sclerosis until it meets these important dissemination in space and dissemination in time criteria. So what exactly is dissemination in space and dissemination in time? So dissemination in space, as the name indicates, is at least one T2 hyperintense lesion should be present in 2 or more of these 4 areas in the CNS, which include juxtacortical white matter or intracortical gray matter, periventricular white matter, which also includes corpus callosum, infratentorial region of the brain, and the spinal cord. So even if one lesion is present in any 2 of these regions, it fulfills dissemination in space criteria. Coming to dissemination in time criteria. So in dissemination in time, a new T2 hyperintense lesion or gadolinium enhancing lesion on follow-up MRI with reference to the baseline scan, irrespective of the timing of the baseline MRI, or a simultaneous presence of asymptomatic gadolinium enhancing and non-enhancing lesion at the same time in one scan is suggestive of dissemination in time criteria. So on follow-up imaging, at least if you are getting a new lesion on T2 or enhancing lesion on post-contrast T1 weighted images as compared to the baseline scan, or on one image we are getting both enhancing as well as non-enhancing, active as well as non-active lesion, it fulfills dissemination in time criteria. So if both these criteria are fulfilled, we can label the patient as having multiple sclerosis. So this is very important. Why? Because there is no serological diagnosis as such for multiple sclerosis. It relies very highly on clinical as well as imaging features. So this is the typical lesion of MS, which should at least be present in more than equal to 2 locations, that is juxtacortical, intracortical, periventricular, and corpus callosum, infratentorial or spinal cord. And this is the dissemination in time criteria, where we see some new T2 hyperintense lesions on follow-up as compared to baseline, or new gadolinium enhancing lesions on follow-up as compared to baseline, or simultaneous presence of both enhancing as well as non-enhancing lesions. So what are the updates compared to the previous McDonald's criteria? So lesion should be at least 3 mm in long axis, one. Second, a positive oligoclonal band on CSF can substitute a dissemination in time criteria. Third, optic nerve involvement is not a part of criteria anymore. So these are very important updates. Then coming to the typical imaging features of multiple sclerosis, which is actually the most common demyelinating disorder that is present. So on T1 weighted images, a typical MS lesion appears hypo to iso intense. A lesion within lesion appearance, that is a peripheral T1 bright signal and a central dark signal, can be seen because of the magnetization transfer effect, that is lipid peroxidation, that is seen in active stages. While in chronic stages, there is no peripheral T1 hyperintensity and the entire lesion is black, which is called a black hole, and it represents white matter destruction and axonal loss. The global cerebral burden of the black holes correlates with the neurological disability of the patient. Coming to the T2 and the flare images, on T2 and the flare images, a very early sign that is to be looked for in case of multiple sclerosis, ependymal dot dash sign, which is a very early MRI feature. And Dawson fingers actually develop after ependymal dot dash sign has been discovered. So Dawson fingers are periventricular demyelinating plaques that are distributed along the axis of the medullary veins, that is perpendicular to the body of the lateral ventricles, which is thought to reflect perivenular inflammation or demyelination. And the important thing is the ependymal dot dash sign precedes this sign, that is Dawson finger, which is very typical of multiple sclerosis. The very important thing that we have to remember is this is very sensitive and it has a very high specificity. Dawson fingers are not seen in any other demyelinating disorder. So if this is seen, that is, this particular case is definitely a case of multiple sclerosis. And that is why I said that 3D flare sequence is the most important sequence that is to be assessed in any case of a demyelinating disorder. Coming to susceptibility weighted imaging, as I already discussed in my imaging protocol, where 2 important signs are to be assessed, that is paramagnetic rim sign and cortical vein sign. So what are the importance of a paramagnetic rim sign and cortical vein sign? So susceptibility weighted images, as we all know, that it contains both phase as well as magnitude images. So on phase image, what we see as a paramagnetic rim sign, this particular sign, that is peripheral hyperintensity in this lesion, is suggestive of a paramagnetic rim sign. And what does it indicate? It indicates chronic active demyelination at the edge. This is very important. A chronic lesion, which is actually appearing as a black hole on T1 weighted images, will demonstrate this particular sign, that is paramagnetic rim sign. And if this sign is present, that means that lesion is actually active. And why is this sign actually seen? It's because of the iron laden macrophages that are present in the periphery, which give this hyperintense signal. Other sign that can help in differentiating multiple sclerosis from other demyelinating disorders is cortical vein sign. And this is because of the typical perivenular demyelination that is seen in multiple sclerosis, that we can see a central vein within this demyelinating lesion. So in this again in this susceptibility weighted images, which is very well, this particular sign is very well seen, even though it is seen in flare also, but on SWI it is very much appreciated. This perivenular demyelination, there is hyperintensity, and within that the central vein is seen. So both the signs have been described in multiple sclerosis, and they are very highly specific to multiple sclerosis. Then another important sequence is T1 post-contrast sequence, where the enhancement patterns are very important. The enhancement pattern can be nodular, punctate, ring, and commonly open ring is seen, where the ring actually the open part of the ring points towards the cortex. The enhancement suggests a breach in the blood-brain barrier and hence active demyelination, and hence it's a disease activity marker, and it is usually seen in the first 3 weeks and may persist up to 3 months. So the enhancing component is thought to represent the advancing front of the demyelination and thus favors the white matter side of the lesion. The open part of the ring will therefore usually point towards the gray matter. Then coming to two important entities that are described in multiple sclerosis, that is clinically isolated syndrome and radiologically isolated syndrome. So clinically isolated syndrome, as the name suggests, is actually where the features of multiple sclerosis are detected clinically, while on radiologically doesn't fulfill the McDonald's criteria. While in radiologically isolated syndrome, the MRI findings are strongly suggestive of multiple sclerosis in the patient. That is, it is following both DIS and DIT criteria, while the patient has no neurological manifestations clinically, or no other clear-cut explanation is present. Two-thirds of this particular category show radiological progression, and one-third develop neurological symptoms in the next 5 years. And the presence of cervical cord lesions, infratentorial lesions, higher lesion load, presence of oligochronal bands, younger age at presentation, and abnormal visual evoked potential are reported as predictors of clinical progression. So radiologically isolated syndrome and clinically isolated syndrome are to be closely followed up. So the role of MRI in multiple sclerosis is not only in the early diagnosis, especially of the clinically isolated syndrome, which are on close follow-up, but also to rule out mimickers of the demyelinating disorders like neoplasms or other entities, and predicting prognosis of the particular disease, and also monitor the response to therapy. Now this is very important, that is monitoring the response to the therapy of demyelinating disorder, and why it is so I'll be coming to in the later part of the video. So the coming to the protocol recommended for follow-up. So clinically isolated syndrome and radiologically isolated syndrome, as I told you, need a regular follow-up, and every 6 to 12 months MRI brain is recommended for them. Spinal cord MRI is not routinely recommended on follow-up imaging. That is because cord lesions will definitely appear on clinical examination before they are seen on imaging. The use of gadolinium is not very commonly recommended on follow-up until required. A practical and cost-effective strategy to assure a delay of 5 to 10 minutes is IV contrast before acquisition of T2 and flare sequences, which are not affected by IV contrast, and then acquire the post-contrast T1 at the end. That saves time. So this is the follow-up protocol for patient who's being treated for multiple sclerosis, where an initial MRI for the diagnosis uh, is done, where gadolinium is recommended according to the imaging protocol. Then a new baseline is taken at 3 to 6 months after treatment onset to determine the disease burden, where gadolinium may or may not be required. Then the first follow-up is done 12 months after the treatment onset, where again the gadolinium is optional. Second follow-up is done 24 months after treatment onset, and follow-ups are then done every year while on treatment. So what to look for during monitoring of a lesion of multiple sclerosis on treatment? So we have to look for disease activity, whether there is any enhancing T1 lesion, a new or enlarging T2 lesion compared to the baseline images. Identification of new lesions in the clinically silent individual may indicate a change in the therapy or the need for more frequent follow-up, and a contrast enhanced MRI on follow-up is optional in relapse and not required in stable patients. So to look for disease activity as well as identification of new lesions in clinically silent individual. which may indicate change in the therapy. So these are very important points to be looked for during monitoring a patient of MS on treatment. So here we have a patient on follow-up. He's being treated for multiple sclerosis, and on follow-up imaging, we get this particular picture on axial and sagittal flare images, where we see hyperintensities in the bilateral cerebral white matter and a large hyperintensity in the right occipital region. And this particular asymmetric hyperintensities are seen, and such large lesions are not very typical of multiple sclerosis, and this patient is actually being treated for MS. So what exactly has happened? So this is actually a case of progressive multifocal leukoencephalopathy secondary to natalizumab treatment. So PML is a demyelinating disease which results from reactivation of JC virus infecting oligodendrocytes in patients with compromised immune systems. So this typically is seen as multifocal asymmetric periventricular and subcortical involvement, and there is little or no mass effect or enhancement. And the subcortical U fibers are commonly involved, with a prediction to the parieto-occipital regions, which was seen in our case. So this is secondary to natalizumab treatment. A patient of MS can develop PML who's on natalizumab, and hence this entity becomes important, and hence treatment monitoring with imaging is a very important thing. Now another such complication of natalizumab is cryptococcal meningitis, which on these T1 weighted images are seen as enhancing VR spaces. Enhancing VR space, enlarged VR spaces are seen in the bilateral capsuloganglionotic region in this T2 weighted images, and these are enhancing with some leptomeningeal enhancement, which is seen. This is again secondary to natalizumab treatment in multiple sclerosis, and this patient has developed cryptococcal meningitis. So, cryptococcal meningitis, the appearances vary from hydrocephalus, dilated perivascular spaces coalescing into gelatinous pseudocysts, leptomeningeal and pachymeningeal enhancement, cryptococcomas, miliary nodules, and choroid plexitis. The most common pattern, particularly in profound immunocompromised patients, spread along the perivascular spaces, most commonly involving the basal ganglia, which was seen in our case. So this is another such case of a patient who's being treated for multiple sclerosis, where we find some hyperintensities in the temporal lobes with dilatation of the temporal horns, which is a case of actually HSV encephalitis, and this patient was on fingolimod. This is actually an immunomodulator that is given as a treatment in multiple sclerosis, and this patient developed this particular complication. And that is why it is again important to image these patients regularly for treatment monitoring. So now concerning the COVID-19 pandemic, here again fingolimod patients who are on fingolimod for the treatment of multiple sclerosis developed severe COVID-19 infections as compared to other drugs. So these are the complications that are there of the treatment of multiple sclerosis that we have to uh, keep in mind. So on follow-up imaging, we also have to monitor the neurodegenerative component of the multiple sclerosis, which can actually be assessed by the burden of the chronic black holes and the global brain and cord atrophy. Brain iron quantification has not yet come up because it is actually a AI developed software. So now coming to important differentials for multiple sclerosis, an important differential is actually CNS vasculitis. It's a very common and important differential that is considered by the clinicians. But how to differentiate between a CNS vasculitis and multiple sclerosis? So these are also multifocal areas of hyperintensity which are seen on the FLAIR images and the T2 weighted images. But the important thing that helps us differentiate between CNS vasculitis and multiple sclerosis is that multifocal areas of cortical infarcts, microbleeds, confluent white matter changes are typical with vessel wall enhancement in case of CNS vasculitis. The classical MS lesions do not show any bleed or perivascular vessel wall enhancement as is seen in case of CNS vasculitis. So on SWI images, microbleeds are very well seen on vasculitis, and vessel wall enhancement and some infarcts are very commonly seen in case of CNS vasculitis as compared to multiple sclerosis. So this is another case which mimics multiple sclerosis in many ways. That is, the lesions are discrete, multiple, T1 hypointense and T2 hyperintense, and they show typical distribution as in case of multiple sclerosis with cord involvement. So cord involvement and optic nerve involvement I'll discuss later on in the video along with other demyelinating disorders and compare them all in one slide. So this is another important entity which mimics multiple sclerosis completely, and the diagnosis will go as multiple sclerosis if the clinician doesn't suspect any other particular entity. In this particular case, it was a case of brucella. The blood culture was also positive. So this patient had CSF pleocytosis, elevated protein, reduced sugar, and anti-brucella antibodies, and occupational history with fever, headache, malaise, and consumption of unpasteurized dairy products. And the clinician highly suspected uh, brucellosis, and hence the diagnosis could be actually made. So only radiology will not help in such cases. You definitely need a good clinical acumen to diagnose such cases. Now coming to the very important question as why macrocyclic agent is used as compared to a linear agent, and because we commonly do a contrast scan in case of follow-up of MS. Now why we need a macrocyclic agent as compared to linear agent is because a molecular structure of the contrast agent which plays a very important role. The macrocyclic structure, the gadolinium is bound more tightly to the chelating agent and is less likely to be released as free gadolinium, while it is more exposed in a linear structure. And gadolinium being toxic, it deposits uh, in the dentate nucleus and the deep gray nuclei of the brain and causes symptoms. So it is better to use a agent which does not have gadolinium free in the structure. That is a macrocyclic agent which includes gadoteridol, gadobuterol, gadoterate, rather than a linear substance like gadodiamide, gadobercitamide. Then coming to the next demyelinating disorder now, that is here we have a 50-year-old female with recurrent episodes of vomiting, gradual loss of vision, progressive paraplegia, and these are all since 2 months. And she has a history of COVID 3 months back. So this is the MRI picture of this patient of the brain as well as the spinal cord, where we can see that there is some hyperintense signal on these T2 and flare images. The dorsal part of the medulla, in the splenium of the corpus callosum, in the corpus callosum proper, and also longitudinally extensive signal in the spinal cord as well, with some peripheral enhancement. So this is actually a case of neuromyelitis optica spectrum disorder, or NMOSD, which is again inflammatory demyelinating disease, which is autoimmune mediated. And the very important target antigen here, what we have to remember is aquaporin 4, which is actually the most common aquaporin in CNS. And it is not the oligodendrocytes or the myelin producing agents. It is actually aquaporin 4. So what exactly is the relation of aquaporin 4 with formation of myelin? So majority of the patients with NMOSD have aquaporin 4 antibodies, and about 30% are seronegative. Both are included in the spectrum, that is neuromyelitis optica spectrum disorder. Aquaporin 4 is actually a water channel protein which allows osmotic transport of water across cell membranes. So it is present in the food processes of astrocytes and are abundant in the circumventricular organs. For example, the pineal gland and the posterior pituitary and the area postreme. And anatomically, the aquaporin 4 is distributed in the optic nerve, spinal cord, periventricular white matter, and the hypothalamus and the brainstem. So these are the sites of involvement typical in case of neuromyelitis optica spectrum disorder. So aquaporin 4s are typically located in the circumventricular organs of the brain, that is the organs which are not within the blood-brain barrier, the outside the blood-brain barrier. These include the subforniceal organ, that is SFO. This is the subforniceal organ, the lamina terminalis, the median eminence, the subcommissural organ, which is here, area postrema of the brainstem. This is very important, the dorsal part of the medulla. And why it is so important, I'll come to in the later part of the video. These all comprise the circumventricular organs of the human brain. They are so named because they occupy the strategic positions along the surface of the ventricles. So aquaporin 4, which is abundant in the circumventricular organs, is actually present in the foot processes of the astrocytes, which are attacked by the antibodies in case of neuromyelitis spectrum disorder. And in this case, there is damage to the foot processes of the astrocytes, and hence these astrocytes, which are actually helping in the process of myelination, as they are the supporting cells of the oligodendrocytes, they get destroyed, and because of this, indirectly there is a demyelination of the neurons, and hence this particular condition of neuromyelitis optica spectrum disorder develops. So the imaging features are divided into four major categories: the lesions which mirror the distribution of aquaporin 4 in the brain, which is particularly found in the periependymal regions of the ventricles, which are confluent, smooth, sessile white matter involvement, unlike MS, and they don't have any Dawson fingers. Periaqueductal gray matter involvement, medial thalamus, hypothalamus involvement, corpus callosal involvement, typically marbled pattern is seen, splenium's involvement is seen. Deep punctate white matter lesions can also appear, which may be similar to MS, and hence it is important to differentiate NMOSD from MS. Corticospinal tract involvement by extensive longitudinal lesions, and larger than 3 centimeter diameter hemispheric white matter lesions, which are relatively rare, can also be seen, which can mimic a tumor. So it is very important to differentiate NMOSD from MS because the treatment of both these entities are different. So NMOSD imaging features typically include acute callosal lesion, which often are edematous heterogeneous, giving a marbled appearance. So this is the marbled appearance of the corpus callosum in NMOSD, along with this arch bridge pattern, that is crossing of the corpus callosum, arch bridge pattern of appearance is also seen, along with the trident like hyperintensity in the corticospinal tract. These are the typical periventricular involvement because of the abundant aquaporin 4. These are again the marbled appearance and the arch bridge appearance of the corpus callosum, trident appearance. The enhancement pattern in case of NMOSD typically is only of two types: cloud-like enhancement and pencil-thin ependymal enhancement. There is patchy enhancement with a blurred margin in the cerebral lesions, are referred to as cloud-like enhancement. These are the cloud-like enhancements that are seen in the post-contrast images. And pencil-thin ependymal enhancement is similar to infectious ependymitis, where there is thin pencil-like enhancement around the ventricles that is seen. This is unlike multiple sclerosis, where we find nodular enhancement or ring-like enhancement, open or closed ring-like enhancement. Incomplete ring enhancement has not been described in neuromyelitis optica spectrum disorder. So this is the pencil thin enhancement and the cloud-like enhancement that is typical of NMOSD. So one of the most specific brain features is the periependymal lesion in the dorsal brainstem involving the area postrema. So this is the hyperintensity in the area postrema. So area postrema is actually concerned with controlling the vomiting center, that is chemoreceptor trigger zone. And in such cases, that is only hyperintensity is in the area postrema. No other symptoms will be present, like this patient will be having recurrent vomiting, nausea, upper GI symptoms, nausea, hiccups, and he'll be frequently visiting the gastroenterologist, who will be prescribing antacids and doing endoscopy with no significant improvement in the condition. In such cases, if the clinical profile fits, should definitely get a MRI brain done to look for any demyelination in the area postrema. So this is one of the types of lesions that can be seen in NMOSD more than 3 centimeter in the white matter bilaterally that are seen, which is relatively rare. Then NMOSD must be differentiated from multiple sclerosis because many disease-modifying agents used in multiple sclerosis like interferons, fingolimod, and natalizumab may worsen the neuromyelitis optica spectrum disorder. And another important thing is that NMOSD is not a very good disease to have because it is associated with other many autoimmune diseases like myasthenia gravis and SLE and Sjogren's syndrome. We have to get these patients tested for other autoimmune diseases as well because there is some 30 to 50% association with other autoimmune diseases. So this is a typical area of involvement of the structures in the brain in case of NMOSD, where there is periependymal surface of the corpus callosum is involved along with hypothalamus and periaqueductal area and area postrema. The periependymal surface of the third ventricle and optic chiasma and the periependymal surface of the fourth ventricle and the area postrema are typically involved. These are all having a lot of aquaporin 4s, aquaporin 4 water channels. This is the typical MRI picture that is periventricular and in the circumventricular organs, the trident sign of the CST involvement. Then coming to the next demyelinating disorder, this demyelinating disorder typically presents in a pediatric age group where a 5-year-old child with reduced vision, ataxia and weakness since the past 1 week and history of recent urinary tract infection uh, came for a MRI brain, and this is the MRI picture of this particular child where we can see on these T2 weighted images some hyper intensities that are seen in the deep gray matter and bilaterally they are present. So this is a typical picture, ADEM like picture, acute presentation and typical lesions in the bilateral deep gray matter. So these typical distribution of the lesions that is in the brainstem, in the deep gray matter and the focal cortical region are typical of MOGAD, that is monoclonal oligodendrocyte glycoprotein antibody disease. And also it can present with focal leptomeningeal enhancement fever. So these lesions have typical distribution as acute disseminated encephalomyelitis. So MOGAD is actually a myelin oligodendrocyte glycoprotein antibody associated disease which represents a group of inflammatory demyelinating disorder which is united by the presence of IgG antibodies to myelin oligodendrocyte glycoprotein or MOG. So it can also present with encephalitis and seizures. And these are the typical pictures that are seen. They are usually asked in the spotters in the radiology exams as flames and fuel. Flames are flare hyperintensity lesions in anti-MOG associated encephalitis with seizures, and fuel is flare variable unilateral enhancement. So they typically present like an infection, but there will be no organism in the CSF. It will be sterile, and in such cases we have to send for serum for MOGAD, and it will be usually positive in these children. Now, some of the imaging red flags for MOGAD, that if these things are present on imaging, we have to consider other diagnoses. These include the lesions are adjacent to the lateral ventricle and are around the temporal horns or Dawson fingers, because that is not very typical of MOGAD. MOGAD lesions are usually like ADEM. They are in the deep gray matter and also in the brainstem. They are usually not along the ventricles. So this excludes the MOGAD as a diagnosis. A silent increase in the disease burden between the relapses or persistently enhancing lesion, that is not a feature of MOGAD. MOGAD is completely, it comes down. after a severe episode. Sudden onset of the symptoms, that is within 4 hours, you have to consider other diagnoses like ischemia, and presence of oligoclonal bands in the CSF. You have to consider MS as diagnosis rather than MOGAD. MOGAD myelitis, coming to spinal cord involvement of the demyelinating diseases, and starting with the disease we are already discussing now, that is MOGAD. In MOGAD, the spinal cord involvement is typically like a pseudosyrinx type, where we can see a sagittal line hyperintensity along the spinal cord. A long segment of the spinal cord is involved, and it shows on axial images a H-shaped involvement, which is also called H-shaped hyperintensity, that we can see on the axial images. That is because of the gray matter involvement, and it gives a pseudo central canal dilatation or pseudo syrinx appearance, as we can see on sagittal image. And on post contrast images, we typically get faint cloud like enhancement, which is a spinal meningeal enhancement that has been described. So sagittal line hyperintensity and H-shaped hyperintensity on axial, because of the gray matter involvement, is to be remembered in MOGAD myelitis. Another important feature of MOGAD myelitis is that it typically involves the conus medullaris. It's considered very highly specific location for MOGAD uh, demyelinating disorder. It is longitudinally extensive. More than 50 to 75% of the patients is seen. And sagittal line hyperintensity, H-shaped hyperintensity, and conus involvement are the three main features in case of MOGAD myelitis. Then another important feature of MOGAD myelitis, what we have to remember, is this hyperintensity in the paraspinal muscles. The paraspinal muscle hyperintensity is very highly specific, along with brain lesions typical of MOGAD, that is brainstem involvement and the deep gray matter nuclei involvement, cerebellar peduncle involvement. So, reversible paraspinal muscle hyperintensity in anti-MOG antibody associated transverse myelitis is a very specific sign, and it is reversible as the treatment is undergone. The paraspinal hyperintensity also subsides. So, it is thought to be having some MOG in the paraspinal muscles as well, which is attacked by these antibodies. And coming to the optic nerve involvement in the MOGAD, the optic nerve involvement typically is bilateral, and the preferably in the retrobulbar region of the optic nerve is involved, and tortuous edematous enlarged optic nerves are seen with severe optic disc swelling and perineural enhancement. So this perineural enhancement, bilateral retrobulbar region with perineural enhancement, is very typical of anti-MOG antibody disease. Perineural involvement and retrobulbar region bilateral is very specific for anti-MOG diseases, or what we have to remember is very important. Optic chiasma is less involved, and a long segment of the nerve is actually involved. Coming to the involvement of optic nerve in case of neuromyelitis optica spectrum disorder, this typically involves the perichiasmatic region of the optic nerve with no evident perineural enhancement. This is also bilaterally seen, and long segment is actually involved. Typically, it involves the perichiasmatic region in NMOSD. And in NMOSD, this is the particular signal change in the cord that is seen. This is called in axial images, is called bright spotty sign, and longitudinally extensive transverse myelitis is seen in the sagittal images. So this is NMOSD positive, where we can see this bright spotty sign and a lentiform enhancement and a longitudinally extensive transverse myelitis. It typically involves cervical and dorsal cord as compared to the lumbar cord. Bright spotty sign, lentiform enhancement, longitudinally extensive. So how to differentiate between NMOSD and MOGAD? These are some important points. MOGAD typically occurs in younger age group, while NMOSD is in middle age females. NMOSD typically has poor outcome because it has so many diseases associated with it, while MOGAD has a good overall prognosis. Posterior optic pathway is involved in NMOSD, while anterior optic pathway and perioptic stranding is seen in MOGAD. Longitudinally extensive transverse myelitis with T2 bright spotty sign with lentiform enhancement is seen in NMOSD, as I have shown in the images previously. While in case of MOGAD, typically conus medullaris involvement is seen with such pseudosyrinx appearance. NMOSD in the brain shows marbled appearance with arch bridging pattern involvement of the corpus callosum. And area postrema syndrome is also seen in NMOSD, while in MOGAD it typically shows ADEM like pattern with brainstem involvement and encephalitis like with seizures. Now coming to lesions in the MS, how the spinal cord lesions and the optic nerve lesions occur are seen in MS, multiple sclerosis. So typically this hyperintense signals that are seen, the short segment that is less than 3 vertebrae is typically involved, and they are patchy, and they usually spare the anterior part of the spinal cord. They commonly involve the lateral and the posterior part of the spinal cord. And optic nerve, unilateral optic nerve involvement and mid segment typically is involved in the case of multiple sclerosis. So multiple sclerosis, spinal cord involvement is short transverse myelitis, less than 3 vertebral bodies, and on axial sections, dorsal and the lateral portions of the cord are involved. In NMOSD, it's longitudinally extensive, and it is showing bright spotty sign on the axial images with more than 50% area of involvement. So it's transversely extensive as well with lentiform enhancement. While in MOGAD, it is longitudinally extensive with typical conus involvement, which is highly specific, sagittal line hyperintensity or pseudosyrinx appearance, along with H-shaped hyperintensity in the axial images, and are very specific for MOGAD. So this is the optic nerve involvement, perichiasmatic optic nerve involvement in NMOSD, retrobulbar involvement in MOGAD, and unilateral short segment involvement in multiple sclerosis. This is the spinal cord involvement. Typically in multiple sclerosis, patchy spinal cord involvement is seen with lateral and posterior cord involvement in the axial sections. MOGAD, you see conus medullaris is very specific involvement and H-shaped hyperintensity on the axial images. And in NMOSD, we see longitudinally extensive transverse myelitis and transversely extensive transverse myelitis as well, as we can see with lentiform enhancement. Brain lesions in NMOSD is typically along the uh, circumventricular organs in the periventricular region, while in MOGAD it is ADM like picture where cerebellar peduncles, brainstem and deep gray nuclei are involved. In multiple sclerosis, the typical Dawson fingers perpendicular to the corpus callosum are seen, and it follows DIS and DIT criteria. Now, another important differential for multiple sclerosis that is very commonly seen in clinical practice is uh, a vascular disorder. So what is the distribution of small vessel ischemic changes and multiple sclerosis? That gives the idea as to what exactly the lesion is, because small vessel ischemic changes also present as T2 flare hyperintensities in the white matter. So some important points to differentiate. Of course, DIS and DIT criteria is there. Other than that, the Dawson fingers, gadolinium enhancement, these are very typical for multiple sclerosis as compared to chronic ischemic changes. And another important feature that I want to highlight upon is that as we see the vessels of the brain, we can see that these vessels have to go a long distance to supply the white matter, and these vessels can actually get involved in case of atherosclerosis and lead to ischemic changes in the white matter of the cerebrum. But the vessels that are in the temporal region, that is the temporal lobe, they have to travel less as compared to the vessels in the parietal lobe, in the frontal lobe. And hence these vessels are the temporal lobes are less commonly involved in chronic ischemic changes as compared to multiple sclerosis. So if lesions are seen early in the course in the temporal lobes, it is likely to be because of multiple sclerosis rather than ischemic changes. Another important thing is multiple sclerosis usually does not involve the basal ganglia, while ischemic changes typically involve the basal nuclei because of the perforating vessels.